So without further ado, I'm going to throw things over to Lorraine.
Awesome. Thank you, Tina, for the very enthusiastic introduction. So my goal today is to cover sort of a mishmash of all things diabetes, not stuff that you might necessarily read in a textbook, but more the day-to-day realities of some of the challenges that we face every day. So thanks to everyone for participating. I'm just looking outside at the beautiful sunshine, and so I appreciate you taking the time to be with us this afternoon. Okay, so as always, I have to say, please don't go running out and buy yourself any new insulin or do anything crazy as a result of this talk. I am going to give some sort of general rules of thumb around dosing. They are general rules of thumb. They may or may not apply to you in your individual situation. So just keep that in mind, and always, before you make any changes, you know, definitely discuss that with your personal diabetes care team. Okay, a little bit of information for me to have about you. Can you just let me know, and I'm sorry, I'm sure you've answered this question like 30 times this weekend, but how long have you had type 1 diabetes? I'm just curious to see the breakdown of newbies to like serious long-term lifers there in the more than 50 years. I know there's at least a couple in that category here this weekend.
Just going to give a couple more seconds for them to answer. We're still waiting on a few.
Awesome. Okay, we have a good mix. Some certainly that are relatively new to type 1 diabetes, and some experienced 41 to 50 years as well, with the bulk of us being between 20 and 30, which is awesome. Okay, next question. Just let me know what tools you use to manage your diabetes. Are you on multiple daily injections? Do you use just an insulin pump? Do you use injections plus a CGM or flash glucose monitor? Do you use a pump and CGM, or do you use a pump, a CGM, and an actual algorithm that helps to control your insulin doses? Get a good mix of who's here today. Oh my goodness, there are no MDI aloners. So anybody that's on MDI in our group is also on a CGM. So wow, and only maybe, it looks like maybe one or two people just on a pump. So we've got some technology users in the crowd as well. Awesome for me to know. Okay. And just a question for you to gauge for me your level of comfort with independently manage your diabetes on a daily basis. So things like making changes to your settings on your pump, or adjusting your insulin for exercise, or even something as practical as, you know, being prepared and taking, you know, packing everything you need for traveling, things like that. How confident are you in your ability? I expect we're going to have some pretty confident, experienced people. We'll see where the bulk land. Okay, so like I expected, we have a pretty confident group of people. We have a couple that, you know, feel like they need a little bit of extras, and I'm glad you're here, because I hope that I'll be able to give everybody at least one or two key tips to walk away with and help you, you know, on a daily basis. Awesome. Okay, so now I know a little bit about you. I like to put this up because it's really such a farce. If you think back to the first time you ever learned anything about diabetes, it might have been grade 10 biology. You know, somebody probably used this analogy of a balance scale and just said, if you just balance the insulin and your exercise with your food, that it's all pretty simple and straightforward. And, you know, I think I don't have to convince any of you that it is far more complicated and far more difficult than just that. You know, whether it's stress, illness, hormones, medications, and the list goes on, there are so many factors that affect our ability to keep this balance scale in check that we really have to acknowledge how difficult it is. And in fact, I like SpongeBob's analogy here. Here's a list of the things that affect my blood sugar. And the list is a lot longer than that previous slide. Okay, diabetes is hard. It's 24/7. It's multiple, checking, even if that's just looking at a CGM, since it looks like a lot of us are on continuous glucose monitoring of some sort. It's lots of pokes. It's balancing meals and snacks with insulin. And, someone said I have to be a dietitian and an endocrinologist and a mathematician and all sorts of skills that we really never counted on having to use in our day-to-day lives, just around the complexity of matching insulin to food. And I know Alana's talking about that right now. Erratic schedules, I don't know. I mean, maybe now with COVID, things seem to be a little more calm, but in fact, my schedule is way different than the norm. So I've had to adjust, make some tweaks to my diabetes management because of the change in my schedule. Carb counting is a nemesis for many. If any of you were on my talk on technology yesterday, I'm hoping that it's something that in the not too distant future will be a thing of the past. But for now, we are still dependent on counting carbs and dosing insulin based on that number and the inherent error that comes with that. My friends used to joke that, as a dietitian, I have a degree in carb counting, and I still mess up, and I mess up, fairly regularly. So, without having the food science background that I have, I can only imagine how difficult, managing the food piece is. Availability, accessibility of diabetes supplies and the cost and the burden. None of us asked for this. And it is a very expensive thing to manage. I will just pipe in here because the four of us were chatting before we started today, and just, kind of randomly it came up around for anyone in Ontario, just letting you know that the assisted devices program is pretty much shut down right now. So if you were lined up to get your insulin pump funding in Ontario from ADP by direct deposit, you should not be affected. But if you weren't set up for direct deposit and you're waiting on a check, there may be a delay in you getting that check. So just look into that. And make sure that you're going to be okay if there is a delay in accessing supplies. Hey, changes in activity, stress, illness, and the list goes on. And so I don't think, again, we're all in agreement that getting this thing right is quite challenging. And I'm going to start with talking around insulin and how difficult it is to find the right dose for a given meal, for a given day. It is really tough. On a large scale, I hope everyone in the room, if you have a ballpark of what your body weight is in kilograms, okay? I just want you to think about this. If you're 150 pounds, it's about 70 kilograms. On average, and I'm giving averages, and again, these do not apply to everyone, but on average, we use about half a unit of insulin per kilogram of body weight. If there's American friends on the call, if you take your body weight in pounds and you divide that by 2.2, that will give you your body weight in kilos. And that, you should be using on average, and some people might be bang on, and some people might be quite off of that. There's a bell curve with sensitivity to insulin. And sometimes we can't explain why some people need, a lot less insulin than someone else for the same age and weight and activity level. So there's not always a perfect match, but if you can just figure out in your head, okay, my body weight in kilograms is about this much, is my insulin dose, my total daily dose of basal and bolus for the day, is it about half a unit per kilo, or is it way, way off? And just keep that in mind as we go through today. Most of us should be close to about 0.5 to 0.6 units per kilogram. Okay, another poll question for you. For my basal, insulin, my background insulin, I use Tresiba, Toujeo, Lantus, or Basaglar, Levemir, NPH. I use an insulin pump, or maybe I use something else. If we've got people from other parts of the world, I might have even named them wrong. Now, I remember most of us were on a pump, but let's see what our MDI friends are using. Okay, so the bulk of MDI users are on Tresiba, and little representation from Toujeo, Lantus, and Basaglar, and Levemir, and 82% of us are getting basal from a pump. Very good to know. Okay, so jumping right ahead. For those of us on insulin, which that is all of us, we have to remember when we look back to the physiology of what it is that we're trying to mimic. We're trying to mimic what a normal pancreas does every single day. This is a picture of what a pancreas does when somebody eats 3 meals per day. But particularly with COVID, you might be eating 3 meals per day and a few snacks tossed in there. So we might have some other bumps in the mountain along. But what I want you to take away from this is a couple of things. Is you'll see here this background or the bottom line, that's your basal insulin that you need 24 hours a day. And there's never a time where that's at 0, okay? So that's a key takeaway is we need basal insulin all the time. We are not producing it and we need to replace it. And then we need to give boluses of insulin to cover our meals, and we need to give boluses to correct high blood sugars when they happen for the variety of reasons that they happen. So you might see a pattern like this. Sometimes people ask me, well, why is the spurt at breakfast bigger than lunch and dinner? And that's because you see even a rise in basal needs, how much insulin we need in the early morning hours. That can be explained by the dawn phenomenon. We talked a little bit about it yesterday, but how people are a little bit more resistant to insulin in those early morning hours, and that carries into breakfast for many people. And if there's any pattern with carb ratios, people tend to use a more aggressive ratio at breakfast, certainly than they do at lunch. Lunch tends to be the time of day that we're most sensitive, and early afternoon relative to supper. So this is kind of just to put into framework for you, whether it's with, you know, a long-acting insulin that's fulfilling this, whether it's a basal rate going in every couple of minutes, and you know, you're pushing buttons to give your boluses, or whether you're giving you know, an injection by pen or syringe to cover this. This is really what we're trying to mimic, and this is the game of type 1 diabetes. So we always want to kind of get a sense. The goal of basal insulin is to keep your blood sugar steady in a fasting state. So if you don't eat any food, really, if we've got your basal rates on a pump, or if we've got your basal insulin dosing correct, in theory, you should be able to keep your blood sugar nice and steady throughout a time period where, you know, it's never flat. You know, even in people who don't have diabetes, we don't see a perfectly flat line. There's always going to be some bouncing around and variability. But if your blood sugar is rising in a fasting state, that's just your liver putting out glucose, and we need more basal insulin to put a cap on that liver to say, hey, I don't need this much glucose right now. I want to keep, you know, I want to stay in this range. If your glucose is dropping while you're fasting overnight, or you're waking up low, then that's a sign that your basal insulin is too high, and you know, we need to adjust and reduce it. Okay, so have you checked your basal rates? And I know this is kind of like, you know, everybody's saying check your basal, and it gets kind of boring. But you know what, every morning that we wake up, or if you're a shift worker, please take into consideration that I'm talking about people who are going to sleep at night and waking up in the morning, but you know, that might be shifted for you. Every time you wake up after a period of fasting overnight is really a basal test. It's, you know, and if you have a CGM, which many of you do, most of you do, you know, that has given us this beautiful picture of being able to look back 3, 6, 12 hours and see exactly what happened with my blood sugar over that time period. So using a CGM is an awesome way to confirm like what's going on when you're not paying attention, and it takes away that need that we used to tell people or ask them to, fast for this period and check here and then check another, hour or 2 hours later and keep testing so we see that those, that your numbers are flat. We don't really need to do that anymore. We've got this pretty picture that we can give. And this, all of these are examples. This is, 8 o'clock at night. And this is someone going all through the night, pretty steady, had a little rise here, and might be a dawn phenomenon, but overall stayed pretty steady between sort of 6 and 7 the whole night. That's confirmation that I'm pretty happy with basal. Here we have another situation where, glucose rises slightly. It's still really tight here. But it actually between 3 a.m. we'll call it, and a little later in the morning, it actually drops into, below 4.0. And this person's sitting low from 5 a.m. until it looks about 9 a.m. Which might indicate, although there's no big rapid drop, might indicate that just overall we're getting too much basal in this time. That's a really, really tight place to be sitting. So you might want to just pull back a little bit on basal in this example. Okay, and just you're gonna love this. If you look and see, this came into my notifications this morning. Sunday, May the 3rd, and I threw this in last minute. And what my message with this is, let your software work for you. The softwares that we have available, and I just maybe a week or two ago turned on some of the additional notifications with my Dexcom, and it's forcing me to pay attention to things that I maybe might have missed before if I'm not retrospectively going in and looking. But I got a notification this morning that I had a pattern of daytime lows in this past 7 days between 4:30 and 4:45 p.m. You'd think that I would have picked up on that just in, a day-to-day, repetitive. And I know, yeah, I've had a couple of lows that I didn't really expect, but so what do I have to ask myself? I have to say, hey, is this a basal problem? Is my basal too high in the afternoon that's causing me to drop, low at this time of day? It really depends on when I ate last, because anytime you have a low blood sugar or a high blood sugar, within the first couple of hours of a meal, it's absolutely more than likely related to your carb ratio or your meal bolus. But if you have a high or a low blood sugar that you're maybe trying to tweak or to fix, and it's happening 4 to 5 hours after your last meal, we can almost guarantee and say that that's probably more related to your basal. So although my pattern is a little bit off, I'm tending now to eat a little bit later for a breakfast on my new COVID routine. And I'm not eating lunch like I used to with, my normal meal times. So I actually hadn't eaten really from maybe 10 a.m. until 4:30. I hadn't eaten at all in this time most days of this week. More because I sit in this chair and I just get distracted and I forget to eat. And hey, that was telling me I have this pattern of going low. So I can tell you for sure that this is a basal issue. And so what should I do to fix it? So when you change basal rates is as important.
Lorraine, sorry to interrupt you. Just because it was relevant to that slide, someone asked if that was the Clarity app or what app was giving you that report.
So that was absolutely Clarity. And I went into Clarity, and in the settings in Clarity, you can set up notifications. Like I say, this is not something I was getting, like even maybe I set it up in the last 7 days. But now every time there's a pattern, or every time some of it is really positive reinforcement too. So every time I have a day where I meet my goal % time in range, I get a message saying, hey, you met your goal today. And, at the end of the day, that's actually just a nice kind of, wow, hey, I had a good day today. But this was also one that I turned on a pattern notification to, force me to really look at if I'm having patterns. And if you are having patterns, one-off events we're not making changes for, generally speaking. But if there's a pattern like I got this morning, and I can tell you based on my eating and my schedule that I know it's related to basal, this is a pretty cool notification. You can get bombarded with notifications from Clarity. So don't turn everything on. Figure out what works, what works best for you. But this was particularly handy. I believe with LibreView, you can also, it also has a pattern detection component. I'm not as familiar with it as I am with Clarity, but this was pretty cool. Okay, so just coming back to making changes to basal, when you change them is as important as how much you change them by. So if I'm starting to go low at 430, my basal rate at 430 is not the problem. Okay, sometimes people will think, okay, well, that's when I'm going low, that's when I need to decrease it. But because of the action curve of our rapid acting insulins, I actually need to back that up, and I need to back it up quite considerably. And you can look at, you can look at this kind of one of two ways. I could back it up by maybe 2 hours and make a bigger reduction, or I could back it up by 3 to 4 hours and make a smaller reduction. I think anytime we're making tweaks with basal, doing it in smaller increments is always more comfortable. When I first started pumping, the pump I had, I could do 0.6 units per hour or 0.7 units per hour or 0.8, and there was nothing in between. We're so fortunate now to have pumps that, you can set basal rate by even smaller than a 40th of a unit, which is, 0.025 units per hour. So backing that up, making a very small change, even if you're not really comfortable making changes on your own, this 0.025 is such a small amount, even if it's over a couple of hours, that it takes time for the cumulative effect of a decrease or an increase on a pump to take effect. So, we always want to back it up 2 to 4 hours before the problem that we're trying to fix. So if you find you're having, blood glucose rises, and our general rule of thumb with CGM is if you're rising or falling by more than 1.1 millimoles, that might be indicative of a need for a change. We used to say 1.7 millimoles, your blood sugar should stay steady within, plus or minus 1.7 millimoles, 24 hours a day, assuming fasting. Okay, that does not include meals. If we're trying to optimize your basal, but they say John Walsh, when he came out with his most recent book, said, oh, hey, we can do better than 1.7 with CGM. We can actually hit 1.1. So if you're rising, starting at 6 a.m., then you might want to change your basal rate, increase your basal rate back at 3 a.m. And, oh, I had to just put this in here this morning, because if your blood sugar is falling at around 4:30 p.m., consider decreasing the basal in the, 1 to 2 p.m. And I can do a small decrease, but I have to go back and look and see how low I was going and take other things like my activity into consideration. And I might want to make just a small decrease, but I know a couple of those lows were pretty big crashes. So I'm going to make a bigger decrease by maybe 0.05 or maybe even 0.1 of a unit for a couple of hours to offset this effect. Okay, and just a question, please throw your thoughts in the chat. What might you do here? So I'll give you some sort of answers off the top. This person is not eating at all, no carbs, and no bolus insulin during this time period. They're checking, and at 11 a.m., they have a blood sugar of 8.3. So some people right off the top go, well, that's too high. And yeah, it's a little above where we would like it, most people want their target to be. But this 11 a.m., assuming this person had breakfast at, 8 a.m., this blood sugar is not likely to be a basal problem, but might be a sign that, hey, we might need a slightly increased or more aggressive carb ratio at breakfast. And, maybe we could turn that 8 into a 6.3. But given that it's sitting at 8.3, this is the time block that we're looking at. An hour later, it's 7.9, hasn't changed very much. 2 hours later, it's gone up a little bit. It's gone up more than our 1.1 millimoles, but not very much more. Again, no carbs, no food during this time. And then at 5 p.m., when they, remember to check again, now they're up to 13. So any comments on how you might fix that? Okay. And remember, this isn't just a one-off. This has happened a couple of times, a trend like this.
So we have ease off insulin at 9 a.m., start decreasing basal at 12 p.m., increase basal at 12.
Okay.
Slightly at 10.
Okay, lots of thoughts. So we
Basal at 2.
absolutely, this is telling us that we need more basal. The rise that we're seeing is way, like that's a big jump at 6 millimoles, almost 6 millimoles in a 5-hour time period. This is indicative that we need more basal. And so we could back it up, you know, the big rise, when's the big rise happening? There's a little rise here, certainly. There's a bigger rise between 2 and 5. So we could go back, we could even go back to 10 a.m. I agree with some people, and maybe increase this to 0.575 and see how that works. We might be able to do, you know, a 0.05 increase. So make this noon value 0.6 and see how that affects, you know, the later afternoon period. So we need more, and it's just figuring out, well, you know, where do we, you know, what time of day do we add that increase, and how long do we extend the increase for? And just seeing this small snippet of the day, we can't fix the carb ratio, and we can't really address supper yet, but you know, it gives you a good idea that we're missing basal there. Okay, what would you do here? And again, please throw some comments in. This is an AGP for any of you that aren't familiar with this. This orange line, this is the median blood sugar. These graphs, you can change the time period that they of data that they use to put this graph together, but they're typically 14 days worth of data. And you see this person sitting about 13 at a median blood sugar, so half their values are above this and half their values are below this. But you know, on average, they're dropping from midnight. This is midnight. They're dropping from 13 by 6, 7 a.m. Looks like they're down to about 7 millimoles. So that's a big drop. If we look, you know, we can't really assess during the day because we don't know what the pattern, you know, this person is eating meals during the day. But, you know, here with this rise before bed, we'd want to ask, you know, is this a basal issue? You know, do you eat dinner at 6 and then you don't eat for the rest of the, you know, you don't have any snacks in the evening? Then we can assume this is, you know, this is maybe it's something we can address with basal. If it's, you know, the pattern I see more often, which is kind of snacking and nibbling and at night, then it's not a basal problem. So we have to ask those questions, right? Sometimes people are just afraid of going to bed. They're afraid of going low overnight. And so they will say, I need to be above 10 or I'm going to go low. And if that's the case, then we have a big basal problem. Because if they're dropping, if you're seeing a pattern like this, dropping without any correction, you know, we need to, this is definitely too much basal. We're too high here at bedtime, but it's not a problem that we're going to fix likely with basal insulin. We probably need to address the eating or the whatever pattern of behavior is happening here. But this pattern is the one that's concerning me, because this person's right. They can't be, you know, below 10 and go to sleep, or they're going to be, you know, very low when they wake up if this is the trend and pattern. Okay. So, and the other thing that makes this more complicated is that within each of us, the data that we've seen from the 670 or the hybrid closed loop with automation of basal delivery, we've learned some key things from this. And one is that from one day to the next, our insulin requirements overnight vary by about 30%. So if you think of your basal rates, half a unit per hour, 1 unit per hour, whatever that is, that, you know, one night you might, if your basal rate is 1 unit per hour, well, one night, you know, you might need 1.3 units. And at the same time, you might, you know, the next night you might need 0.7. So that's a big variability of how do we get this right? Most of us have one set of basal rates, and it's kind of surprising, you know, or not surprising that this doesn't work out well every single day, because there is so much intra variability from one day to the next, and that is about 30% overnight and about 20% during the day. And what are the reasons for this? It could be what we're eating. It could be our changes in activity. It could be changes in sensitivity for us women. Every day of the month seems to be, you know, throw a little bit of havoc, and certainly some parts of the month throw more havoc than others. And some people, particularly for you know, menstrual periods or some people will have a specific pattern for that. Oh, it's okay. You know what? I know I'm getting my period. I'm going to flip to this pattern. And, you know, there's not good data to suggest that doing that is giving us all that great of success. It's certainly better than doing nothing, or maybe some people are handling some of these things with temp basals when they know they've been more active, and that could be beneficial. But, you know, setting alternate patterns may not be the solution. Really, what the solution, I believe, is automation that's going to take care of a lot of this for us, and just adjusting basal based on what our sensor is saying, and taking us out of that equation is huge. Now, basal insulin is usually, and if you don't know, I would encourage you the next time you take a look at your either your pump or if you do, you know, if you're on MDI, do some quick math and figure out, is your basal dose somewhere between about 40 and 60. I would say, you know, 60 is probably on the high end, 40 to 50, 30 to 50 of your total daily dose. You know, most of us fit in there somewhere. However, there's lots of situations where we will not. So for anyone that is consistently less than 50% of their total daily dose as basal, what kind of things, when would we expect this? Well, if you haven't had type 1 diabetes that long, you know, your percent of insulin from basal might be lower. If you eat a lot of carbs, the biggest thing that affects this is the type of diet that you follow. If you eat a lot of carb, your bolus percentage is going to be much higher than somebody who doesn't eat very much carb at all. We might see their total daily dose 80% of basal. So the norm with auto mode on 670 is to see somewhere between 30 and 50% of the total daily dose from basal. I think that's what we're seeing on other, you know, hybrid closed loop systems of the DIY variety. And, you know, where you might see somebody using more than 50%, like I said, with a lower carb diet, it might be someone who's just got a little bit of insulin resistance. They're maybe not as physically active, maybe have had diabetes longer. And certainly anytime when I'm looking at reports and I see 80% of basal, 80% of total daily doses basal, and I know the person isn't on a low carb diet, then I am worried about missing boluses. And I love this quote. Okay, this is from Will Dubois from Diabetes Mind. It's a number of years old, but remember that basal's job isn't to fix shit. It's to keep it where it is. So if you go to bed at 10 and you wake up at 10, the basal did its job. Its job is to hold the line, nothing else. Now, if the line is in the wrong place, because maybe you have a carb ratio or a carb counting that's not happening, you've got a problem, but it's not one you should be fixing with a basal rate. I love it. Okay, tip around bolus. So, you know, once we've got this basal sorted out, then we want to look at, okay, are we adequately covering meals with insulin? And are we able to bring down high blood sugars, high for whatever reason, back into our blood glucose target zone appropriately? And what does that mean? I love this. I'm going to just throw it in because on Facebook, often I see people say, you know, they might be newer on a pump or newer to diabetes, and they throw in like, hey, like, what's your ISF? Or, you know, and it, to see people with this wide range of different responses, it just echoes how different diabetes is for all of us. I will tell you before the answers come up that most of us fall with a carb ratio between 1 to 5 and 1 to 25. Okay, about 80% of us should be in that ballpark somewhere. But there are going to be people that are more resistant to insulin and who need more than that for their food on the low end. And there's going to be a small percentage of people that are very sensitive to insulin and need less than that on the other end of the spectrum. So let's just see whether we fit the predicted, and we pretty much do. There's our 4 to 20. Okay. So these folks need a little bit more insulin for every gram of carb than these folks up here, and that's just type 1 diabetes, but we fit the match. So if we check the ratio, we want to do this once we're pretty sure that the basal, hey, we know basal's never going to be perfect. Are you waking up with a good blood sugar most of the time? Are you steady after periods of fasting? You know, once we're pretty confident that we've got that right, then we can check out the carb ratio. And we don't want to check a carb ratio when we still have insulin on board, or when we've had a low, or we've been stressed out or exercising. So, you know, of course, find the perfect time, a normal time to do this. That sometimes doesn't exist. But we want to encourage pre-bolusing. So when you are testing your ratio, do it a favor and give it that 15 to 20 minutes of a head start on your food. Eat a food that's relatively, it's lower in fat. We know that fat causes our blood glucose levels to go higher later on. So we don't want to mess around with fat, and we don't also want to be really, you know, too much estimating with the carb counting. So sometimes people will use a packaged food item where the carbs are right on the box and you eat a certain amount. Sometimes people will use a scale and they'll measure out, you know, a cup of rice and they know exactly how much carb it is. Whatever, that works. You know, this is one of John Walsh's recommendations, is to test your ratio with about 1 gram per kilo of body weight. But you know what? I don't agree with that. I think I don't eat anywhere near 1 gram per kilo per body weight in one meal. So I think it's really what we need to do is to test your carb ratio with the amount of carb that you eat on average with your meal sizes. So whatever that is for you. And we're gonna, you know, have a look at the blood sugar before the meal, see what's happening a couple of hours later, and then we're going to see, well, where are we coming back to several hours after the meal, and what are we aiming for? Any thoughts? I'm going to, just in the interest of time, I'm going to tell you that we're aiming to keep that blood sugar at the 2-hour mark, somewhere between 2.2 and 4.4 millimoles, higher than, you know, where we started, assuming we started with an in target blood sugar. And we know the ratio, it's doing its thing if we return to within 1.7 millimoles of our target at the 4 to 5 hour mark. So this is just a little picture of that, is if I start my meal at 5.5 and I go up to maybe 8.3, and then at 4 hours I come back down to 5.5, like that's kind of the curve that we'd love to see for most of our meals. But you know what, if we go up, if you start at 5.5 and you go to 12 and you come back down to 9, if that's your pattern, then it's an easy fix. We just know that your carb ratio isn't aggressive enough, and we need to give a little bit more. And to do that, if my ratio here is 1 to 15, then I might, you know, make this one 1 to 12. Don't make, you know, big adjustments with your ratio. 1 to 2 grams, generally speaking, is a good amount. Now, if your carb ratio is in the 4 to 6 range, you might want to adjust by smaller than that, by half a gram per unit. This one's a little more tricky to figure out. So if you're not rising very much after a meal, that might be from a low glycemic index food, it might be a high fat meal, there might be lots of things, but we need to know, well, what was the meal? Assuming it was a cup of rice and some chicken and broccoli, a very, you know, standard, straightforward meal. We might assume if you've only gone up to 6.6, say at this time, that, you know, we've overdone it and that ratio is too aggressive, and you're going to see a low in the 3 to 4 hour time period. So if that were the case, then my ratio of 1 to 15 might become 1 to 17 or 1 to 18 to prevent that from happening on an ongoing basis. There's just some guidelines. Again, these slides are all available, so, you know, don't worry about writing anything down. There are some guidelines for how much to adjust for when you're making changes to your carb ratio. A quick rule that I learned a few years ago, and I think this may or may not work for you. I'd be curious to hear your input in the chat. If you do the math quickly for you, if you take 2.6 and you multiply that by your body weight in pounds, or if you know in kilos, because we converted it earlier, 5.7 times your body weight in kilos, and you divide that by the total amount of insulin that you use for the day. So Mary is 130 pounds and she uses 28 units per day. If I do this quick formula, it would predict for me that her carb ratio, you know, might be around 1 to 12. And it might be 14, it might be 10, but I wouldn't, you know, this is pretty aggressive. You know, it's not a rule that I would use for somebody who's just starting on a carb ratio. And these data are also for people on pumps. So although that's the majority of the crowd today, just keep that in mind, that these formulas were calculated for people who are pumping insulin. Forgetting to bolus. Okay, so missing 2 meal boluses in a week can cause A1C to increase by 0.5%. And if you miss 4 miss boluses in a week, even if you're eating, relatively low carb, and you eat more than 10 or whatever that number is for you, grams of carb, and you see that post-meal rise, that can cause a significant increase in A1C over time. This is an old study, but it comes back to remind us how important it is to make sure that we don't forget.
Lorraine, I just want to let you know we have about 13 questions in the question box.
Perfect. Okay, I will run through this quickly. Just a reminder too, when you give up a correction bolus, how quickly do you expect the blood glucose to return to target? I ask this question of people all the time. Please throw your answers in the chat, but I'm going to jump ahead and tell you the answer, is that some people will tell me like 30 minutes and others will say 2 hours. And if you think back to how that action curve of rapid insulin is 4 to 5 hours. So when we give a correction for a high, we're not expecting that blood glucose to be back to target until much later. We have to let that correction have its full effect. We should not see lows. So if you tell me that you're back to target in an hour after giving a correction, look out between 1 hour and 4 hours, because we're going to see hypoglycemia, and your ISF in that case would be far too aggressive. One of the formulas that we use to determine ISF, and you can even just do it, in your head if you want, but if you take 100 and you divide that by your total daily dose, this is a millimole formula, that should give you a ballpark of your insulin sensitivity factor. So if Mary uses 35 units per day, we take 100, we divide that by 35, and that tells us her ISF should be around 2.8. Again, if these formulas don't work for you, do not make any changes on your own, but it might be time to review, all of your numbers with your diabetes educator. And insulin sensitivity isn't static. It changes all the time. Most of you, I'm going to guess, have 1 ISF programmed into your pump, or if you're on MDI, you know that 1 unit brings your blood sugar down by 2 millimoles or something like that. However, that 1 unit might bring you down by 2 millimoles in this particular instance, but tomorrow when your situation is totally different because you had a high-fat breakfast, or because you were really physically active, our sensitivity to insulin is going to change. So remember that it's not static. All of these things and a whole big list more of other things affect how sensitive we are to insulin. And so we think that we have this 1 ISF. Really, what we should be looking for is, does it work for us most of the time? And that is success with an ISF until we have fully automated systems that can do a lot of the work for us. Okay, I have one more polling question, so I want to get that in. In terms of sick days, what's your sick day plan? If you've been over 14 for several hours, you're not feeling well, you're nauseous, you're perhaps vomiting, you're exhausted, you just don't want to get out of bed. Our first thing that we would say, and many of you probably answered with, I'm going to check and monitor my blood glucose closely. And at that level, with 2 high blood glucose levels after about 14 over an extended period of time, and I would say, more importantly, this is key for unexpected highs. So if you had a site failure, yeah, of course you're going to have a high blood sugar, or you forgot a bolus. If you can explain why you're high, then I'm less concerned about you going down a sick day plan than if you are really not feeling well and you can't explain your hyperglycemia. That's more concerning. So I'm really curious to see your answers here. Do you have a way to test your ketones at home right now? If any of you got sick, and with COVID going on, this is something we need to be extra diligent about. Do you have a way to test your ketones right now? So I have a blood glucose meter and I have strips for it. I have the meter, but not sure if it has strips. It does not come with strips. If you haven't opened the box, there are not likely any strips inside, unless your educator gave you strips or you've bought strips for it separately. I have unopened urine ketone strips. I have opened urine ketone strips. If you have opened urine ketone strips, they're only good for 6 months. There's 50 of those things in one of those little canisters. They're cheap. It's an inexpensive way to test your ketones, but it's better than nothing. But they don't last very long, and we don't tend to use them or need them very often. And no, I do not have any way to test for ketones right now. Really curious to see your thoughts. Okay, so About a third of us do not have any way for testing for ketones. So if you take one thing away from today, if you have type 1 diabetes, please talk to your healthcare team about some method. If you're on a pump, I really do believe it should be a blood ketone meter. Blood ketone strips are expensive, but just to have one or two on hand in the case that you might need them is what it's worth the expense. So lots of people have opened urine ketone strips. If they've been open for more than 6 months, they're probably not going to be good anymore. And others have, unopened urine strips, which is awesome. And half of us or a third of us are totally prepared. So if we look at some DQ&A data, in the US of type 1s, 60% of people reported having a ketone test kit, 72 in Canada. So I think our numbers are a little lower than that. And, having the meter is one thing, having the meter with strips is another. If your blood sugar is above 16 on 2 tests in a row, this is when we want to pay close attention to ketones. If you happen to be on a diabetes medication called an SGLT2 inhibitor, so those are called canagliflozin, dapagliflozin, or empagliflozin, Invocana, Jardiance, and DAPA is, anyway, it's escaping me the trade name at the moment. But look it up if you are on one of these medications. You'll need to test your ketones when your blood sugar is even a lot lower than that, and that's especially if you're not feeling well. And these would be used off-label in type 1 diabetes. And they're all of your clinics, and on all sorts of different web pages, you'll see some guidance around what to do when your blood sugar is in this range and your ketones are in this range. And when we get concerned is if your ketones are 3 or more, especially over a period of time, you need to probably get to an emergency room. And I'm not going to get into that in a whole lot of detail right now. I just want to get to one last tip before we stop for before we stop for questions. Is around treating hypoglycemia, because this is one that I know I struggle with. It's really hard to not clean out the fridge when you've had especially a bad low, and I find bad lows are lows when I've dropped really quickly, and that onset, that sudden feeling of when that happens. So we want to treat with the right types of carbs. We want fast-acting carbs. That might be for you glucose tabs. It might be some sort of liquid juice or regular pop or soda. It might be candies. My trouble with carrying around little sleeves of Rockets is if I have nothing else and I'm just a little hungry, I might be tempted to snack on them when I don't need them. So I that is a risk I take. Dried fruit. I really love dried mango right now. So like 1 or 2 little pieces of that is more than enough to bring me back up. But I think where we really struggle is not with, we know what to take. Now, not everybody uses fast carbs, but how much? And we have to remember that one size does not fit all. So you're not gonna be able to use the same amount of carb for every low, because there's so many things that affect your individual situation. And from one low to the next, you might need, a 2.8 might need more carb correction than, a low of 3.6. So what other things do we want to think about? Well, how big of a person are you? Because that affects how, whether you need 15 or whether you need 25. What's your total daily dose, particularly how much of it is coming from basal? If you've been active, we might need, to correct your low, but we also might need a little bit of extra recovery carb. If you have insulin on board, always a good idea to take a little bit extra. A severe low, automated insulin delivery is one where you need less. If you are on a hybrid closed loop system, because that system has been trying by pulling back your basal to prevent this low, you're going to need less carb. If you correct with 15 or 20, you might find you do have a rebound afterwards. So, recommendations are anywhere between like 6 and 12 grams for somebody on an automated system. Really hard to stick to that. And diet as well. If you're a low carber, some people that are keto or follow very low carbs, they need a very small amount to bring them up. It really varies individual to individual and low to low. One formula came out that I saw recently, which was, if you, again, I'm throwing all these kilo body weight formulas at you, but if you work out, well, what is 0.3 grams per kilo of body weight for me, 70 kilos? This is suggesting, I might need about 21 grams as a ballpark for correcting hypoglycemia. This was published study just a year or two ago. And you can individualize by watching what happens when you treat a low with your CGM. If you are, what I commonly see is I do overdo it, and I know that that's something I've got plenty of evidence to support that that's a behavior that I need to really work on changing. Okay, I'm going to stop there. Other than to say sorry, I'm sorry, I want to leave time for questions. Carry a syringe with you at all times. Okay, anywhere you go, make sure you have a syringe in your pocket, in your meter case, in your purse, in your pocket if you need to, because pumps fail, and you always are more than likely to have insulin in your pump. You can, with many insulin syringes, pull insulin out, and if you ever had a pump failure, a set failure, and you're not at home and you don't have any way of getting insulin into your body, this will be a lifesaver. Okay, I'm going to end there, and I'll just fast forward through some stuff so we can get to back. Let's go to questions. I'll just put my contact information up there. If anyone has stuff they want to contact me directly, I'm totally happy to hear from you. But let's dive in. Okay.
The half unit per kilogram for total, was that for the total daily dose or basal?
Total daily dose. Okay, so it might be 0.5 to 0.6, and then we say about 0.3, 0.25 to 0.3 for basal, and about the same for bolus if somebody's, at a 50-50 ratio, but you would adjust that if you're not 50-50 from the get-go. And again, don't change anything based on what I'm telling you. I'm just giving you the background on how we calculate these things. At least for someone starting on insulin, we would probably start around 0.6 units per kilo on MDI. And for pumps, it's usually a little bit lower than that.
Okay. If your blood sugar is high but stable, does that mean your basals are correct, but you need to maybe look at your insulin sensitivity factor, or do you actually need more basal?
So if your blood sugar is flat at 10 overnight, like Will Dubois said, that is probably not a time. If you're flat, that's what we're trying to achieve with basal. But my question would be, well, why did you get to 10, and what caused you to get up there and then to stay there? So it might be, carbs that you didn't count properly. It might be a carb ratio that needs to be tweaked. So, basal's not going to fix the problem. If it is fixing the problem, then that's a concern. So if it's going up and staying flat, it's not usually a basal problem. We got to figure out what got you up there in the first place.
Okay. Should you basal test for a few days before changing your insulin settings? I was told not to change settings based on only 1 day of data.
Absolutely. You need to see a pattern or a repetition, or like I said, my experience like this week, getting that pattern alert come into my inbox this morning of, oh, wow, yeah, I have been low at 4:30 this week. Maybe I need, because the pattern was flagged for me, now that's really good reason for me to go back in. But if it just happened once, if I had 1 day where I went low at 4 o'clock, no, I can't fix the basal for that. It's when there's a documented repetitive pattern, and it may not happen every day in a row, so be careful there. And I didn't look back to see in the last 7 days, was it every other day? Was it, particular days when I was doing a certain activity? I didn't look because there was a significant pattern, and I did suspect my basal is too high in the early afternoon.
Okay. If you see a rise in your BG at a certain time while fasting, what time would you make the change to that basal? An hour prior to the rise or 2?
I would say 2 to 3. You can even go 4 hours back with a very small change. So depending on your pump or system, if you can do tiny increments, then the smaller the increment, the better for safety, for you making adjustments on your own. And then you can build up your confidence in slowly increasing over time. But if you make too big of a jump, then you run the risk of overdoing it. So I would say small increments over longer periods of time, or a slightly bigger increment over 2 hours, but 1 hour in advance isn't enough.
Okay. I only have one basal program on my pump. Is it advised to have multiple depending on the time of day? Mine seem okay for the moment, except I go a bit lower at night.
Okay, so the question there is that basal patterns or basal rates? So
I think they're saying they have one basal rate all the time.
So that is, in type 1 diabetes, that is unusual. One of the reasons why people go to pump therapy is because it allows us to have a little bit more basal here when we need it and a little bit less basal there when we don't. And so on average, we see most people have 3 to 5 different basal rates. That's just, again, a generalization. One number across the board working for you, unless you're in auto mode where it's not on a 670, where it's not really relevant, is unusual. It's not uncommon to see a type 2 on a pump that has just one rate. But in type 1, we have a little bit more hormonal and sort of diurnal pattern with our basal requirements. So it would be unusual to get by with just one rate.
Okay. This person is looping. I bolus for coffee and often get a rise that comes back down, but loop tells me I entered the right amount of carbs. What do you think about factoring this into my morning basal instead of trying to remember to bolus for it?
Yeah, I mean, if forgetting to bolus is a problem, and it's a consistent pattern, you do the same, you're doing this at the same, you're drinking coffee at the same time every day, 7 days a week, then sure, a basal adjustment to offset that, it makes total sense. I would just be concerned if on Saturday you slept in a little bit and you didn't have your coffee, is that going to cause you some grief?
How long would you suggest that we wait after making adjustments to basals, observing results before making any additional changes?
So it depends on what effect you see with the change that you make. If you see a big change, then and it's a negative change, it's not what you want, then you need to probably change it right away. But if it's that you increased your basal and it's better, but you feel like you still need to increase it again, I would say 2 to 3 days to have it to watch before you make another increase.
Okay.
And don't be afraid to reach out for help. I mean, as much as most diabetes education centers are closed right now, all of your educators are accessible and available by phone. So don't be afraid to reach out. They're there to support you right now. So, if you're not comfortable, don't feel that you have to do this on your own. There's lots of people there to help.
For carb counting, did you get that? Carb counting is a tongue twister. Say it 3 times fast. For carb counting, are we taking into consideration fiber or just straight carbs?
So I'm going to guess answer that differently if you're Canadian or American. So in Canada, we generally teach people to subtract carb from everything, regardless of the amount of fiber, and just bolus based on net carb. In the US, that's not generally how people are taught. So they might say you don't really worry about fiber unless it's more than 5 grams per serving. So my practice and my routine and what I do personally is based on fiber subtracted.
Okay. How do you properly fast for medical or religious reasons using basal injections? So
if you're going to be having a procedure, colonoscopy, let's say, one thing that might just to be recommended to err on the side of safety is a temp basal reduction. And again, depending on how comfortable and how tight you are with managing your own diabetes and what your own individual glycemic goals are, this may vary. But I know I had a colonoscopy like 4 or 5 months ago, and because the last thing you want is to risk hypoglycemia Because if you have to treat it, then you're not truly fasting, and it could, mean that you don't have your procedure, or you have to go through that god awful prep, again, and all the work you did was for nothing. So, in that situation, or if you're having surgery or anything like that, I err on, I'd rather run sort of between 8 and 12 than risk dropping low. So I might do like a 30% reduction in basal across the board until I've woken up and I'm out of the procedure. I'd rather run a little high than risk lows while fasting.
Okay, this is an MDI question for someone who's taking Tresiba. They've had no food since supper, but they see spikes at 2 to 3 a.m., 5 to 7 days of the week. Basal is fine during the day. Should they consider a pump?
Yes. Yeah, because I mean, the goal with Tresiba over time is that it's really meant to not, we're trying to avoid it, or it's a flat profile, and that's supposed to be, the benefit of it. But if your needs aren't flat, it doesn't necessarily always work. And with CGM, like years ago, when we didn't have visibility to this and people weren't up checking at 2 and 3 o'clock in the morning, like we didn't know what was happening. So we would probably say, oh yeah, your basal's fine. But now that you see it, and if you see it, repeatedly, you might be a candidate for a pump, because you might need a little bit more basal during that time, whereas the basal that you're getting for the rest of the day is actually okay.
I have a consistent challenge with dawn phenomenon and breakfast. I have a huge increase in basal starting at 3 a.m. and continues until 10:30. I also take a large bolus with breakfast, so I don't get a huge spike after breakfast. However, if I eat lunch late, I risk crashing. My doctor told me to reduce that morning bolus, but then I'll wake up really high if I sleep late on the weekend.
Okay, so that means that if you wake up really high when you sleep in, that means without food, your body's really dependent on that bolus for keeping your blood sugars kind of in check. That would say to me that you probably need a little more basal. And I would be worried about an overly aggressive carb ratio if it's resulting in lows pre-lunch. There's a couple of little tricks that we sometimes teach for people who have this every single day. The first they would probably look at is, is there a change we could make to what you eat at breakfast? Add in some protein, make sure, there's protein and fat to sort of calm the spike. And maybe then, you don't need as much bolus that would then cause a pre-lunch low. Some people will play with temp basal increases and smaller boluses, or bigger boluses and then temp basal decreases sometimes works. But those things are really individual, and I would say work with your team. Think first about how can you minimize resistance with what you eat in the morning, and is there a fix with some lower carb and lower GI and higher protein, higher fat foods that might make just managing breakfast easier.
Okay, we've got just a couple more and then we'll wrap up.
Mm-hmm.
I think my basal overnight is good, but I still see a slight rise at 3 a.m. Could it be insulin sensitivity factor?
Not unless, okay, so does this person say whether they're looping or
I know, I was thinking the same thing. They don't say that.
Okay.
It just says if we're changing our basal 2 to 3 hours prior to when we want to see changes, what about ISF?
Okay, so ISF only factors in if you're giving a correction, right? ISF, you can set it at whatever you want. If you're not giving correction boluses, it's not, and I'm assuming not automated, okay, and just regular dumb pump land for regular pump therapy, unless you're giving a correction at 11 p.m. or 12 o'clock, then I might be thinking about ISF. But if there's no correction, then it's the only insulin that you're getting is from basal, and that would be the one that we need to tweak. If you're correcting at 11 p.m. every single night, and still finding you're higher at 3 a.m.? Well, it could be, but then my question would be, why are you correcting before bed?
Okay. Regarding basal rates, if you find a perfect rate, will it remain the same 7 days a week, or will routine change things that will require a change to your basal?
The only constant in type 1 diabetes is change.
Yep.
So, and it's, you know, if you're an adult, like, just be grateful that you're not a growing child, because you know, just when you think you get something right with a kid, they grow a tiny bit, or, you know, even for us, we lose a couple of pounds, we gain a couple of pounds. We're a little more active today than we are tomorrow. Like, any little shift in so many other factors. You know, I don't think there is a perfect basal rate. I think it is the best we can do with the tools we have available is to hope that, you know, we've got the settings that are going to work well for us most of the time. And if you can use a temp basal feature when you think you might, if you've been less active, some people use a temp basal increase if they've been less active. If you can, you know, increase and decrease basal as needed, that might, you know, or based on predictive things where you would expect yourself to be going higher or lower, to be more or less sensitive to insulin, that, you know, that might help. But there's no perfect answer to that. Yeah.
So that prior question we had about basal and ISF was from a looper. So
yeah,
answer changes a little bit.
Yeah, it does. It does. So one of the common trends, though, with looping is relative to dumb pumping, people need way less aggressive ISFs. And so I don't know, it's a tough question to answer without knowing what changes, you know, have been made from just standard pump therapy. But if you haven't pulled back your ISF quite significantly, you know, your problem is the opposite, that you're running higher. So maybe you have, and maybe then, yes, a slightly more aggressive ISF might help, you know, 0.2, 0.3 millimoles lower. So if your ISF is 4, you know, maybe try 3.8. And see whether that makes a chance. But it's hard for me to really answer that without knowing, you know, your basal bolus split and lots of other things.
Okay. I noticed a wicked spike when I break my fast. Is that hormonal?
So that is probably not even just from breaking the fast. It's what we call the feet on floor effect. So many of us, years ago, we used to say, well, I need, you know, people would say, I need a wake up bolus. Some people would take a unit of insulin as soon as they get out of bed, just because they see as soon as you start, your body goes into a hormonal motion of whether it's thinking about getting to work or your drive to work or your, you know, just starting your day and getting your metabolism going again does cause a big spike for some people. And I think it's been happening for years and years. We're just seeing it now with so many people using flash and continuous glucose monitoring that we're actually putting a name to it. And it is the feet on the floor effect. As soon as you get up, expect to see a bit of a spike. So can you, you know, if you get up at the same time 7 days a week, yeah, you can maybe offset that with a basal increase. But if you don't, then, you know, I tend to offset it by just pre-bolusing for breakfast, because I know most of the time, well, at least when in pre-COVID time, as soon as I get out of bed, like, I'm going to jump in the shower, I'm going to blow dry my hair, and I'm going to the toaster to put my 2 slices of toast in. So like, I had that routine, and by pre-bolusing, that prevented that feet on floor effect. But you know, it really depends on your consistency, the consistency in your routine.
Would it be the question includes about if they're breaking their fast for Ramadan. So it's actually it's happening at the end of the day.
Okay.
Towards sunset. Yeah.
Well, that, you know, and that makes sense as well. There's a lot of studies that have been done on not a lot, but there's studies been done on intermittent fasting as well as fasting with Ramadan. And, you know, many people with type 1 diabetes choose or try intermittent fasting, thinking that it's going to enhance their insulin sensitivity, when in fact what it has shown us is that that first meal, when you break the fast, you are far more resistant to insulin for that initial meal than we would have ever expected. So that is a very common, it's a common trend. And just know that when you're after an extended period of fast, you're going to need a more aggressive carb ratio for that meal than you might need for other meals or when it's not Ramadan.
Okay, we have to wrap up. Thank you so much, Lorraine, on behalf of the SIM team and all the participants for this webinar. There were some awesome tips and tricks there. I was even madly writing things down as you were talking. Just to remind everybody, this has been recorded. The slides will be available, so you're welcome to go back and check in on anything. On the behalf of Team SIM, a big thanks to all of you for joining us this weekend. There is a wrap-up happening at 1:15, which gives you 2 minutes to go to the bathroom. So get on that, and we'll see you at the wrap-up in a couple minutes.
Awesome. Thanks, guys.